Professor Srinath Chandrasekharan. And again, I cordially invite our speaker, Dr. Thaha Musthafa. He's going to talk on risk stratification in non-muscle invasive bladder carcinoma and newer intravesical chemotherapeutic agents.
Good morning, ladies and gentlemen. Thank you, Slaus and Saus, for giving this opportunity to talk on this topic, risk stratification and newer intravesical chemotherapeutic agents. I have no disclosures. This is what I'm going to talk about: the graveness of non-muscle invasive bladder cancer, risk stratification, newer models and scoring systems, intravesical therapy, what is practiced now, and what is new in the market. The graveness, as you all know, 5-year recurrence rate is 50 to 70%. Even with post-op single installation, 5-year recurrence rate goes up to 45%. Again, the progression rate is around 10 to 30%, and 1/5 of patients will progress to invade the muscle layer. And with CIS, it is going up to 40 to 83%. And 40% of patients will relapse despite of initial success with BCG. So what are scoring models? There are a few. To start with, URTC 2006, which used 1973 WHO classification of grading, and the patients were not exposed to BCG, and there were no second TURBT. There were 6 domains, and the highest score will get 45% of 5-year progression. And there are online risk calculator app as well. On the other hand, Q2 model, it's for patients exposed for BCG for 6 months duration. Validation studies has shown these 2 protocols or 2 systems has poor to fair capability of stratifying risk of recurrence and good to fair capability of stratify for the risk of progression. URTC 2016 model, it has used WHO 1973 grading system, CIS excluded, and there were no second TURBT. Prior disease recurrence and the number of tumors were most important factors for disease recurrence. Age and WHO grading system or 1973 grade system were the most important prognostic factor for overall survival. The risk stratification system will guide us for primary treatment, to schedule our surveillance, and to guide us for adjuvant treatment modalities. So there are a few risk stratification schedules, NICE guidelines, 2019, EA guidelines, AUA guidelines. The recent one is 2021 EA guidelines, which used 4-tier system using 1973 and 2004 grading system. And if there is more risk factors, they fall into highest risk group with, where we consider upgrade cystectomy. This Sankey diagram shows there is transition of patient from 2019 to 2021. Intravesical therapy, we know that aim is eradication of tumors and to reduce the recurrence and progression in completely resected tumors. Guidelines, as you all know, in AUA, NICE, EAU, where the highest risk patient will go into BCG or radical cystectomy. What is practiced now? Post-op single installation, the studies have shown primary tumors, it is beneficial only for primary tumors and intermediate risk tumors less than 1 recurrence per year, and the tumors should have 2006 URTC recurrence score less than 5. And we should emphasize BCG maintenance dose should be there to reduce the progression rate. And the schedule, we know that only the SWOG protocol should be practiced to reduce the progression rate. What is BCG unresponsive non-muscle invasive bladder cancer? When there's BCG failure, it can be BCG resistant or relapse or refractory. Early relapse and BCG refractory patient will fall into BCG unresponsive patient, where we consider newer intratherapeutic agents. The first one to start with is sequential intravesical chemotherapy with gemdosi, which has shown more than 80% disease or high-grade recurrence-free survival. There is ongoing phase 3 trial, Bridge 3 trial, to compare gemdosi online. Device-assisted chemotherapy with use hypothermic intravesical chemotherapeutic agent, which has shown beneficial in the overall survival. IV controlled drug delivery system, Sunrise study, there are 6 studies which has shown there is controlled delivery system of gemcitabine for over 7 days, which has shown there is increment in complete response rate of 73%. Immunotherapy, Quilt 3 study, they have interleukin-15 superagonist, which has shown more than 70% complete response rate at any time. Next one is gene therapy. That's the first gene therapy approved by FDA, and it has shown patient with CIS complete response rate 3 months at 53%. And there are studies going on for neoadjuvant therapy, and phase 3 trial is going on for mitomycin preoperatively at 7 days and 14 days. In summary, I would like to tell chairpersons and the audience, non-muscle invasive bladder cancer, significant progression and recurrence despite the standard of care. Standard of risk stratification should always be updated and improved because the treatment strategy changes over time. Current risk calculators overestimate the disease progression. BCG still remains the most effective treatment strategy, and effective second wave therapy is an unmet need for patients needing radical cystectomy. And there are novel agents in the market, but there are lack of randomized control trial we have faced to compare both agents. Combination therapy might enhance the efficacy of BCG in non-muscle invasive bladder cancer. Thank you.